this conference, I prefer to start with this angiogram. Donc, as you see, when we look at this angiogram, there are many questions to ask. How to treat this lesions, these bifurcations? Should we use one stent or two stent? If we use one stent, should we use one wire or two wires? Should we use a simple crossover strategy or side branch intervention? And if we use the side branch intervention, should we do pot side pot or kissing balloon technique? To answer to this question, I think that the first step that we do is to identify which type of bifurcation. In my mind, there are three types of bifurcation, as you see in this diapositive. The type 1 is the false bifurcation without any disease of the side branch. These lesions are frequent, more frequent in COBIS 2, which represent 53% of bifurcations. And there are also the true bifurcations, two types. The type 1 with short lesion of side branch, and the type 2 with a long lesion of side branch. We also should analyze the angulation and the importance of the classifications to guide our therapeutic strategy. What's the current practice? As you see in this registry, Ultimaster registry, which included more than 3,000 patients, one stent was the dominant strategy with 80% of procedure, while two stent only 20%. Donc single stenting remains the dominant strategy in bifurcation lesions. And if we look at the consensus of European Bifurcation Club, one stent strategy is recommended for the vast majority of bifurcated lesions and is based on a provisional side branch stenting philosophy. What means this philosophy? In fact, that means that provisional side branch stenting is a treatment philosophy rather than a technique, and POT is a systematic part of the standard approach to bifurcation lesion treatment. And nothing else if the side branch don't need attention. This is a Nordic 3 spirit. So I think that identification of clinically relevant side branch should be the first evaluation step for bifurcation lesions. What's a relevant side branch? It's a side branch which had a reference vessel diameter more than 2 millimeters. It's a side branch which represents a significant territory, more than 10% of myocardium mass and impacting prognosis. And donc we know for more than 20 years, that revascularization, that in terms of ischemia risk, revascularization is better than medical treatment when moderate to severe ischemia exists. But if the zone ischemia is not very large, medical treatment has also a great place. And in European guidelines, revascularization is only indicated for a large area of ischemia that exceed 10% of left ventricle mass. This is a very interesting paper which is published in the JACC in 2017, which identify the coronary artery side branch supplying myocardial mass that may benefit from revascularization. And in the multivariate analysis, only the side branch length more than 73 millimeter and the left main bifurcation are predictors of large area of ischemia. So they need revascularization. But if we have a branch that not exceed 70 millimeter, I think there is no benefit to revasculate this side branch. And it is in this same paper, donc, there is an identification of side branch which supply more than 10%, and as you see in this diapositive, most side branch don't supply more than 10% of myocardium and cannot cause more than 10% of ischemia. So this branch don't need any revascularization. Only the left main, the left main bifurcation and marginal branch may have benefit from revascularization. What about clinical trial in COBIST registry? Donc, it's not a clinical trial, but it is a observational study. As you see here, donc it's a registry who investigate 5-year outcome of simple crossover stenting compared to side branch opening. It's a registry which included more than 2,000 of patients, and the result of the registry, there is no difference in terms of target lesion failure between sample crossover alone or side branch opening branch. Recently in EuroPCR 2023, a very interesting trial was presented. Trial KISS, provisional stenting in bifurcation lesion, benefit of side branch intervention. It's a trial which included more than 600 patients, no left bifurcation lesions, with side branch of at least 2.25 millimeters, two groups, no further intervention in first group and side branch intervention in the second group, and the primary endpoint was peri-procedural injury or infarction within 48 hours. The result of these trials in intention to treat analysis, the primary endpoint was observed in 4% of patients in no further intervention, while 5.7% in the group of side branch intervention, meeting the criteria of no inferiority but no of superiority. And if you look at the group of side branch intervention, sample strategy with pot side pot was superior in terms of primary endpoint than kissing balloon technique. The other advantages of the sample strategy without intervention of side branch is a shorter procedure, less radiation, low volume of contrast, and the target lesion failure at 1 month did not differ between the two groups. But as you see, midterm follow-up is necessary to confirm the benefit of the sample strategy. How to prevent side branch occlusion? I think the most important step is to have two wires, so a wire in main branch and a wire in second branch. And as you see here in the COBIST registry, only the J-lead wire in side branch was the only predictor of side branch recovery in COBIST 2 with significant P value. The second step is to choose the stent diameter according to distal main vessel and not to proximal main vessel to prevent carina shift, because stent overexpansion is the most important mechanism of side branch occlusion after main vessel stenting. Third, I think the pot have a strongly role. The aim of the pot, as you know, is required to optimize the proximal main vessel stent diameter, and it facilitates distal recrossing and reduce the risk of abdominal wiring. In this registry Ultima Stare, the pot have have strongly benefit in terms of target vessel myocardial infarction, target vessel lesion revascularization, TLF and stent thrombosis with net benefit.
1 minute, Dr. Bali.
Okay. After pot, it's I think that it's recommended nothing else if we have a good result, as you see in this diapositive from the ABC, the last ABC consensus bifurcation. Exception for the left main, I think we should do pot side pot or kissing balloon technique, but to the other branch, it's not necessary to do that. Only if we have a compromise of a side branch, in this case, we can do the other steps. To conclude, I say that more than 50% of bifurcation lesions have no disease in the side branch. They are false bifurcations. And most of the side branch cannot cause more than 10% of ischemia. then the identification of the clinically relevant side branch should be the first step evaluation. Single crossover technique with sample pot, I think that this can be used in the majority of PFK lesion. Protect and gel side branch. Choose the stand according to the distal main branch and final pot. Therefore, don't too much. Keep cool with the side branch and keep it open. Thank you for your attention.